Well, welcome back from lunch. I'm delighted to introduce a fellow anesthesiologist, Dr. Thomas Mark, who heads the Department of Anesthesiology at Summa General Hospital in Akron, Ohio. And he's going to talk to us, the title is up there, about checklist process improvements. And I know he's going to talk a little bit also about how they're approaching opioid usage. Welcome.
Thank you. So, hello. Thanks for having me. Yes, my name's Thomas Mark, anesthesiologist. I'm the chair of the Department of Anesthesia at Summa Health Systems, 3-hospital system in Akron, Ohio. Just to give you a little background, I trained at the Cleveland Clinic, stayed up there for several years before coming down to Summa. Little background on our health system. We do about 26,000 surgeries, mostly at our large facility, Akron City Hospital. We're about 4,500 births, high-risk OB, level 1 trauma, neuro, fairly good size cardiac program that involves pretty much all the normal stuff that people are doing today with cardiac. So we're a large tertiary care center with the same issue that everybody has, and that's a lot of sick patients and a lot of challenges to deal with. When I talk to, I spend some time, mostly clinical still, but I spend some time talking to C-suites from different hospitals. And every time I talk to them, I hear, that, they basically consider their anesthesia group to be good if they're not hearing about any problems, if there's no, cancellations, if no one's complaining, if they're not asking for more of a stipend kind of thing. And I find that interesting because, somehow anesthesia has exempted itself, at least in my opinion, from providing value, kind of being on the hook for the value that you can provide, from process improvement, to responsibility within all of surgical services. So just to give you a quick overview of some of the things that, our anesthesia group does for our health system. So through utilizing checklists and different process improvement methodologies to clinically improve our patients' outcomes through length of stay, readmission rate, we have worked with the hospital to show that we save about, very, very conservatively, about $16 million from when we started all these different projects per year in how our patients do. In addition, I do a presentation on throughput. I would think that we have some of the best throughput in the nation. Off the national benchmarks, we save about $6 million per year. If you look at, a variable cost of OR time being about $8 a minute. Our cost per case, so our anesthesia cost per case, because of the ratios that we're able to run, because of our utilization of checklists and technology, we run about $6 million, $140 per case, cheaper than the second best in all of team health. So we're, about $6 million better than the next person, and that's pretty standard across the United States. So all in all, including increased volume from a lot of the things that we piloted and have successfully accomplished, we're contributing somewhere around $30 million annually to our bottom line of our parent hospital. They obviously not only recognize it, but very much appreciate it. We did all this with, the use of checklists. I'm a big fan of Atul Gawande and all that, but then also process improvement to make those checklists actually work. All my anesthesiologists are lean belt, at least green belts in Lean Six Sigma. And then also, finding that keystone habit that leads to all the changes that, you want in your surgical services, when it comes to, what you're able to implement through checklists and process improvement. So, I'm going to get to it in the next slide. This became our Keystone habit. Okay. And what I mean by that is, my goal was to eliminate opiates, not reduce them, eliminate opiates from what we do. And, anytime you have a Keystone habit, I mean, you need to define that non-negotiable goal. I find that, so many places say, well, we're working really hard at that. And then when you measure how they're doing, it's not that good. I noticed even with myself, we've been using checklists for a long time before we had the ability to really layer it in with technology. I thought, hey, mean pressures, keeping mean pressures above 60. Cleveland Clinic did a huge study showing mortality even with one pressure under 60. So we said, okay, we're going to really try to do this. And I thought we were doing a great job. And then we measured it, and over 50% of our cases had a mean pressure under 50. I mean, now we're 99%. But till you're able to, define that non-negotiable goal and then implement it into the culture. I talk to people all the time that say, hey, we do a great job, and then when you actually measure what they're doing, it's they find out that it's actually quite different than what they might think that it is. So come back to that slide. Let's see here. So opiates. So I chose opiates for two reasons. As kind of a keystone habit to really work on our checklist and our process improvement. And this is one of them right here. I don't know how many of you know this, but this study's been done many times. It started at the University of Michigan, and the CDC did a study that showed, regardless of the intensity of the surgery, doesn't matter, half-hour surgery versus a 8-hour intensive surgery. A full 6 months of patients were taking opiates 6 months after their surgery. So think about that. We're in Ohio, one of the worst states in the nation as far as the opiate crisis. Summa County is one of the worst counties in Ohio. And to me, my guess is everybody out here knows somebody in their family or friends that had surgery at some point in their life and later, found out that they're addicted to opiates. And it's very real. So these are patients that come in that are opiate naive, never had an opiate before. And 6% are using 3 to 6 months later. 2% of those patients go on to a diagnosis of opiate addiction. So right there is a reason to say, geez, do we really need to use these opiates in surgery? The second reason is what we call ORADs, opiate-related adverse drug events. So when you look at these, the key is 13% of patients, and this study's been done multiple times. It's always somewhere between 10 and 13% comes back the number. And 13% that receive an opiate during surgery have an ORAD. And this is the consequences of an ORAD. So somewhere around $8,000 in cost to the institution. Obviously, the complications that the patients have, which is paramount. You have 1.6 to 2 days added onto your hospital stay. The mortality rate goes to 2.9% with an ORAD versus 30 times less without an ORAD. So you start to look at this both on the cost and the quality of care, and then you pair that with opiate addiction. You say, why would we give an opiate? If there's any other better way to do it. So obviously this became a keystone habit for us, and became one of our non-negotiable goals. So, from there, you said, okay, we're going to put in a series of checklists. We're going to eliminate that master builder in all of us, right? So you have physicians, well, I do it this way, I do it this way. And we're going to say, let's create some standards around our ERAS protocols. And so we built ERAS protocols for each individual type surgery, and then customized to patients' comorbidities. I would have liked to utilize, what other places are doing, but quite frankly, there's not much out there about this. So we really did kind of reinvent the wheel, except I don't think there was a wheel. Most places, as you know, have ERAS for colorectal or maybe for their total knees. We said, well, geez, if we're going to spend the time doing this, and this is so important, and we're trying to eliminate opiates, why wouldn't we, right from the start, why wouldn't we run an ERAS program for every single patient that goes through surgery? And so that's what we've done. We average somewhere around 5 to 7 multimodals per patient. I'm going to talk a little bit about that here in a minute. We start in PAT. We talk to these patients. We set the expectations where they're supposed to be, but we also put them in their own, we customize a pain plan for them in their PAT so that they know what to expect and they know how it's going to work, and they know what their responsibility is. And we also have, when they show up on the day of surgery, we're not trying to design a program at that point, but it's already designed for them and ready to go. I'm going to spend probably most of my time on the regional block program development, just because it's a good example of how a Keystone habit works and what you can do. So part of our ERAS obviously is regional. And, when we started this process out of our, 40,000 procedures in 2020, 22, 23, however many OR cases that we have, we were probably doing about 1,500 blocks per year, slightly above 5%. And that's probably right now the national average. I've gone to programs where, they really have a, in their words, a great regional program, and they're doing about 15% of their cases that they involve a regional block. So we standardized and said, okay, let's figure out all the different types of blocks that we can do for our patients and incorporate that into our ERAS. So we currently today do about 18 different blocks. And we last year did 13,000 blocks. So we're over 60% of our patients coming through the OR get a regional block. So what's the problem with developing that? Well, each anesthesiologist has a different, comfort level with blocks. Well, I don't know how to do that block. Or maybe they're really busy that day and they have several patients or rooms they have to attend to, and they don't have time to do the block. And so consistently performing blocks, for post-op pain can be a really challenging thing for anesthesia providers. And it shows by the number that we do and the number of standardizations that exist today. So we set about to say, okay, how can we eliminate all the variability? So I created with technology being what it is, we have ultrasounds. It's like playing a video game. And we trained some of our really highly qualified CRNAs and turned them into a block team, a regional team in the operating room. Currently, my CRNAs have the ones who have been with us the whole time doing this, have probably done 20, 30, 40,000 blocks because they've been there so long and they've been doing so many of these. So they get a really good skill level. They can handle any block coming. So that excuse is eliminated. The next thing we did was we said, okay, well, let's standardize how we do the blocks and the medication we use when we do the blocks and the whole process of doing the blocks. So one of the things we did, we partnered with Lighters Pharmacy out in Colorado and created a mix. Now our mix, we created so that, we didn't want to have situations where, you get your block and you go home and 6 hours later, the block wears off and the patient's in tremendous pain, comes back and is readmitted. Happens all the time. One of my family members lives here in Boston, broke her wrist, went to one of the prestigious places here, got a block, had the surgery, got home. By the time she got home 6 hours later, pain was so bad she passed out, ended up back in the hospital. So we designed a medication that everybody uses. It's in a pre-filled syringe, so we don't have to draw it up. So we have precision in the mix, and we always know what's in it, and we know that it was drawn up properly. It saves, to draw up medication probably takes 5-10 minutes. You have to go get the medicine, you have to draw it all up, you have to mix it. We saved all those steps by having pre-made syringes. So it's grab and go. Our mix for our more vascular blocks lasts about 30 hours. It's very economical. Our mix for some of the less vascular areas like ankles, our tap blocks, some of those blocks we're getting 4 days, 5 days out of this. So it's a tremendous benefit. Our total knees, we send home the day of. We don't have pain for 5 days. So we took that out of the mix. Surgeons then came to us and said, well, we don't want to be delayed, while you're doing these blocks. So we developed pit crews. So not only do I have this team, but they come in the room at induction, and while we're doing everything else, they do the block. Our average block now takes 178 seconds. So just under 3 minutes. Because we have grab and go medication, we document between rooms on our phones. So every patient that should get a block or is capable of getting a block, we block. And we do it in under 3 minutes on average per block. But then something interesting started happening as well. And this is where the Keystone habit starts to come in. My CRNAs, we have a case. I talked to you about throughput and how much we save on throughput. So I started noticing that, this pit crew would kind of descend on a patient and the CRNA would need another IV, or they would need an A line, or they needed a second pair of hands for glide scope. And I had an expert right there helping them out. So they would, while they're doing the block, then they'd go over and throw in the A line, the IV. And so where, the ASA says, you should add 15 minutes to the start of every case if you have a difficult airway, then you should have, then if you have to put an A line, every procedural event that you do adds 15 minutes to the time of the surgery. Our average, time to anesthesia release is like 11 minutes because it's very much pit crewed. And so that contributes to surgeons. And then because we're eliminating opiates, at the end of the day, the patients wake up quicker. Anesthesia, we push the beds. So, excuse me. So our turnover times, our average times are about 20 minutes in a big tertiary care center, including going to the ICU, et cetera. So all in all, we're knocking off about 30 minutes a case in our throughput. And these are some the trickle down effects. Then I have the CRNAs, talking to me, everybody's about efficiency all of a sudden, right? And they're saying, well, now we're so efficient and you want me to use 5 or 6 multimodals. How do I do that? Because I have to draw all these drugs up. I'm transporting the patient. I only have 5 minutes because right after induction, everything's already done. So I went back to lighters and we created pre-made syringes for most of our multimodals. So like ketamine or Precedex, a lot of different things, lidocaine that we use, they're all pre-made, and we made them in doses that correspond to our drip rate for an hour. So I know when I pull this medication, I have 1 hour, I just plug and play. So we just put the the pumps right there, and now it's very, very easy. And I guess that's one of the keys, is marrying process improvement with your checklists. So it's one thing to have the checklist, but if they aren't easy and if they don't work well, people aren't going to use them, or they're not going to use them successfully. So we married our process so that now it's really easy. And our CRNAs would rather grab those. They don't have to label them. They're pre-labeled. They don't have to worry about outdates. Pharmacy doesn't have to worry about outdates. And so we've been able to create a system that now is very replicatable for every patient that comes through. So the patient comes through, they come from PAT, they know what ERAS protocols they're going to have. It's all spelled out for them. They have all the tools at their disposal to get them done. And we are nearly invisible to our surgeons as far as no matter what it is that's going on in the OR, we're ready in 10 minutes because of the pit crew type mentality that's developed. And now we've taken that beyond, well, let me talk about first, before I talk about that, let me give you some results here. And this slide isn't quite up to date. We started here at the 9th percentile with our patients' satisfaction with their pain. That was back in 2016. We averaged 20 milliequivalents of morphine per patient. We are down to 0.34. It's 99% reduction in the opiates that we use. We do a full, last year we did 91%, 91.6% of all our cases opiate free at a big tertiary care center. We're not where I want to be. I want it close to 100. I want it at 100, but we're getting there. At the PACU, the current number is down to 2. So we're only using 25% of the opiates that we were previously in PACU and recovery. And our last number for our patient satisfaction was 91% percentile. So you can see that we've gone from 9 to 91 percentile in patient satisfaction with their pain by eliminating opiates. What does that tell you? I mean, maybe it tells you that they're not really needed and they're not really good for pain, and there really shouldn't really be the first line. It's just you have to do all this work to put in a process and the checklist to make it happen. But once you do, and oh, by the way, you get the benefit of, you know, serving your community, not having as much addiction. You get the benefit of ORAD reduction at $8,000 per. That's quite a benefit, and the patients are much happier, you know, with their pain control. So I think that's, you know, that kind of data is pretty impressive. We've seen a dramatic decrease in length of stay for many of our inpatient surgical cases. For example, our urologist came to us, and for like, just as an example, the robotic cystectomies typically are 6 to 8 days in the hospital. I have a couple relatives that are urologists, and they, plus the colleagues at the hospital, tell me they just can't get it down under that. We're down to 3 days at Summa. They came to me and they said, "What are you guys doing?" You know, because we're literally sending these patients home, you know, 3 to 4 days. Our breast program, we're doing reconstruction, you know, where you do the excision, reconstruction, flap, and then we're sending them home the next morning. Many of them are ready to go to home the same day. Our total knees, we use catheter programs. The total knees are going home same day. They're having early rehab, and what we're seeing, you know, I've talked to the orthopedic guys, and what they're seeing is that a month out, these patients are doing dramatically better because of all the early rehab that they were able to have, because they don't have pain, you know, inhibiting, you know, that early rehab. And then in addition, you know, with 13,000 blocks, you get that revenue, you know, which, you know, obviously is important. The decreased anesthesia cost per case, you know, a lot of that comes by the application of all kinds of checklists that we employ. So for example, you know, that Keystone habit, right? Moving people to do something differently. We put in checklists around mean pressures, around lung protective ventilation. You know, I thought we were doing a great job with lung protective ventilation, and we measured it. You know, now we have the technology to measure it, and we have the technology to give real-time alerts if people are not doing it. Well, turns out that about 70% of our cases were failing some measure of lung protective ventilation. Now we're at 100%. Every single patient has PEEP, every single patient has the right tidal volume, every single patient has size, because again, we built in the checklist and whatnot. And that has stemmed from basically the opiate project, and expanded outward. A little bit of what I was just talking about. And we've expanded our program to now work kind of in collaboration with ICU and the ER. So now ortho will call us when they have a fractured hip, come to the ER, and instead of giving morphine down to the 97-year-old that then doesn't know their name for the next 2 days, we drop down and do the block in the emergency room. Then 12 hours later, or whatever the time is, when they come to the operating room, their block's still working, they're comfortable, they've had a good night. And we've avoided those issues and those complications. And so we've been working with ER to try to expand, for lacerations, for dislocated shoulders, to take our team and utilize our team, or help them develop their own team, where they can kind of replicate a lot of what we're doing in the OR and the ER. In addition, we do the same up for the ICU. So a lot of our trauma patients, broken ribs, different types of injuries that didn't come to the OR, we'll go up and we'll block those patients for their pain control. And so, the last piece of this is obviously our acute pain program, which we started a couple years ago at behest of the hospital. And it's been very, very important because, what we didn't want to have happen is we do all this good work in same day and the OR and pack you, then they go to the floor and get, a whole bunch of narcotics. So we've taken our ERAS protocols and then moved that to the floors through our acute pain program. We've had some surgeons, there's challenges. Surgeons don't want to give that up. They want to take control of their, total control of their patients. And so we did a study showing, we looked at all the patients that should get, that qualified for Tylenol and Advil. Very simple, right? Up on the floor. And said, how many of those patients are actually getting their Tylenol and their Advil? It was 2%. Now, obviously, since we've taken over, it doesn't mean that we have to be involved in every one of those patients' care, but talking to the residents, we have residency programs, talking to the residents and to the surgeons about what they should do and helping advise them. Now we have that number, in the 90s. Again, it should be 100, but we're making progress. So we've tried to layer in from the beginning to end, how do we eliminate opiates for the obvious goals that I talked about? And we're most of the way there in the journey. We still have opportunity to improve, but at the same time, when you look at the cost of not doing this, when you look at the cost of not, holding your anesthesia department responsible for a lot of the outcomes within surgical service, because quite frankly, when it comes to throughput, and when it comes to patient quality outcomes, and when it comes to even some collaboration with other departments, your anesthesia department is probably in a better position to influence how things go and the quality outcomes that your patients have, than pretty much anybody else within surgical services. So one other thing that I'll mention, the Aspire program. So it's basically a lean Six Sigma program that we put together as we started to do things like pit crew our inductions and a lot of the different checklists. We said we had other people from other departments within surgery say, hey, you guys, could you help us with this? Or could we do, I had nurses, OR nurses say, you know what, this is what really drives me crazy and this slows us down. Could we fix this? We could save money over here. So we've completed 114 process improvement projects within this group. This group is comprised of sterile processing, OR nurses, surgeon, anesthesia, about 10 different subsegments of the OR. We've totaled up about $3 million in annual savings. from the programs and the process improvement that we put together with this program. And then, countless other just efficiencies from aggravation and time and whatnot. And that was a direct result of, having the other people in the OR watch and observe what we were doing with opiates and what we were doing with process improvement and checklists and saying, hey, maybe we can do that too, and this was just simply creating a venue for people to express that. So with that, I guess I'll see if there's questions or.
Sure. We have a few minutes to take some questions. So I'll ask you one. What kind of effort did it take to get the surgeons on board with this, since they're the ones who are usually going to be called about postoperative pain, not you?
So a lot. It was actually somewhat of an arm wrestling competition at first. I spent a lot of time individually talking to surgeons who really try to take good care of their patients and are very involved in every little thing, to get them to kind of let go a little bit and let us help them. And it did take some time. I can tell you now that I have surgeons that will not do their cases anywhere else. They bring their patients, like a couple GYN guys that literally, will not operate without the blocks, will not operate without, what it is that we do, because they see the results. So, once you win them over and once you demonstrate, like, through some of the data that I showed you, once you demonstrate that and they see the feedback of how their patients are doing and what their patients tell them, how happy they are with their surgeries and their outcomes, then it becomes easy. But it's definitively a little bit of a struggle at first.
What about open heart cases? What's your approach to that?
So we developed an ERAS protocol for the hearts. We use a ton of ketamine throughout all our, the micro doses of ketamine throughout our ORs, and ketamine's great for the cognitive dysfunction protection for our cardiac patients. So we've had great success whittling down our time to extubation in our cardiac program because of our elimination of the opiates with them too. And yeah, you'd think, it's been such a mainstay of cardiac anesthesia to give, 20 cc's of fentanyl for that stability. And we've managed to eliminate that and actually improve, how our patients do post-operatively. So.
And ERAS stands for Enhanced Recovery After Surgery?
Yes.
Yeah.
Yes.
Great stuff. Yes, sir.
So I think what you've done is pretty phenomenal. And I was just curious, and particularly with the opioid problem, not just in Ohio, but all over the place, including my state. But do you help other hospitals ever, or do you have a mechanism for doing that?
We do. I don't, I don't do it as a business, but we have, I probably have some hospital system or anesthesia group in every other week, taking a look at what it is that we do. We think the problem's important enough that, we're going to share what we have. I just did a talk for CMS where I shared a lot of our ERAS protocols and what it is that we do for other hospitals. So that, because as you point out, it's a ubiquitous problem and it's a really bad problem. And yeah, we do.
Good. That's good to know. Thank you.
Mm-hmm.
Hey, Dr. Mark. I'm fortunate enough to have actually been working with Dr. Mark for years and seeing the uniqueness of his program. And if you could talk to the audience about what I find interesting is I don't usually see anesthesia getting along with pharmacy very well in all my experiences. And these guys have been able to work together so well. And the process you created, the standardization, if you could talk to the audience a little about how that standardization has worked out for not only you, but the pharmacy side, some of the efficiencies they've been able to create, and just a collaboration with that Keystone
Yep.
of eliminating opioids, I think that would be beneficial.
I mean, I give really all the credit to the pharmacy department. They at Summa has been, spectacular. They've understood that even though they have their budgets, our ERAS protocols increase their budget. It's probably about $35 a case. Now, every block we do, they get about $50. So we've offset it. Plus, we work with them. We try to create win-wins where, we've basically almost eliminated IV Tylenol. And so our budget for IV Tylenol is negligible because we've built in PO plus all these other multimodals. So we try to be very respectful of their budget, but they've been phenomenal helping us. And quite frankly, stuff like you guys have developed with these pre-made syringes has helped them as well, as far as stocking, as far as, outdates, as far as staffing for them. So, coming at it very collaboratively and as a team has been fantastic. And, I know that most hospitals have this, hey, we want to use this expensive drug. No, we can't because we don't have the budget. And so we've been able to foster a very collaborative working together relationship for the betterment of the patients and their outcomes. So it has been something that's pretty special.